And first of all, the outset, I thank Dr. Sajesh from USV for giving me an opportunity to be the speaker of this evening. I am Dr. Sepuri Krishna Mohan, endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Kurnool. So, a very good evening, dear my professional colleagues. And today we are going to talk about the role of statins in diabetic dyslipidemia. And definitely it's a challenging task. So, to start with, I regret that the statins are being very much underused in our country, where there should be aggressive usage of statins. A country like India, where the cardiovascular disease is at 2 times risk, and where this particular statins are going to play a major role in reducing the atherosclerotic cardiovascular disease. Uh, I'm sorry to say this, but still majority of the doctors are not initiating or are under using the dosage of the statin. Like the ideal dosage of rosuvastatin will be 20 to 40 milligram, or the atorvastatin 40 to 80 milligram. They are using 5 milligram. I don't understand what that 5 milligram of rosuvastatin is going to do. See, even the atorvastatin, they are using 5 milligram to 10 milligram. It's not going to serve the purpose. And first of all, I would like to tell you that always remember that everything should be used in the dose specified, and they follow the recommendations of the either the American Diabetes Association or the American College of Cardiology and the American Heart Association. And we also have one this Lipid Association of India. They recently formed 4 or 5 years ago, or Lipid Association of India. It has got its own Indian guidelines. And you got American Atherosclerosis Society. At the same time, you have the European Atherosclerosis Society. So these are the bodies, and finally we depend on the NCEP ATP3 guidelines as far as this dyslipidemia is concerned. And the reasons for not using this may be on the part of physicians, that is typically called the clinician's inertia. Let it be a primary care physician, let it be a physician, let it be a diabetologist, let it be an endocrinologist. The usage of statins is very low actually. And even though they are using the statin, they are not selecting the proper statin that particular patient as per the guidelines or the recommendations. And the second thing is the like where you are supposed to use 20 milligram, you are using 5 milligram of rosuvastatin. That doesn't serve purpose. And the difference between the atorvastatin and the rosuvastatin is a potent statin actually. So 10 milligram of rosuvastatin is equivalent to like 20 milligram of atorvastatin. Like 20 milligram of rosuvastatin is equivalent to 40 milligram of atorvastatin. So even though the one factor is the clinician's inertia, second factor is the patient's inertia actually, because even the doctor prescribes, the patient will not take the tablet. He will take he's got diabetes, he's got hypertension, he's got dyslipidemia, and family history of heart attacks, family history of strokes and all. But still the patient doesn't purchase because he doesn't know how important this particular the role of statins in the presence of type 2 diabetes mellitus, or in the presence of comorbidities like hypertension. So, and the lastly I would like to say, I regret to say that the doctors are not getting updated regarding the latest molecules. So updation is part of our life. Until our last breath we should keep learning, so that you will not be lagging behind in the rat race. And to begin with, I would like to always say ABC. Remember, ABC doesn't mean that you control cholesterol very meticulously. LDL is somewhere around 70 and everything is fine. Don't be under impression that alone dyslipidemia is going to control your the complications. So always I start with saying ABC. The A stands for A1C. You maintain meticulously the A1C around or less than 7 as per the American Diabetes Association recommendations, and around 6.5 or below as recommended by the American College of Cardiology and the American College of Endocrinology and the American Heart Association and even the American Association for the Clinical Endocrinologists. And to be on safe side, as you go down the line 6.5, maybe the patient he may be at risk of getting into hypoglycemias, especially the nocturnal hypoglycemias, the L3, the level 3 hypoglycemias. So it may be a very troublesome problem. So I would like to put it as the target of A1C must be like they related to age actually. If the young patient with no comorbidities is able to tolerate, you keep it as 6.5. And some elderly patient with comorbidities, you put it as 7. So in between 6.5% and 7% would be ideal for everybody. And for the elderly, you give relaxation above the age of 70, 80. You see to that the A1C is maintained at 7.5 to 8% so that they don't get into hypoglycemia because of their cognitive impairment, because of so many comorbidities. There may be the dementia, maybe the presenile dementia, maybe the Alzheimer's disease and all. And first thing is A. And second thing is B. All the time B stands for blood pressure. See to that the patient maintains a systolic blood pressure of 120 to 130 millimeters of mercury and a diastolic of less than or around 80 millimeters of mercury. This is mandatory. No changes at all. Okay. So though the European guidelines vary, but the goal doesn't differ from that of the American Society of Hypertension, the European Society of Hypertension, the American Diabetes Association, even the American College of Cardiology, the American Heart Association, even the International Society of Hypertension, even the British Society of Hypertension. All the international bodies came to one consensus that maybe the definitions vary for hypertension, but as far as the target is concerned, it should be less than either 120 or 130 of the millimeters of mercury of systolic and around 80 millimeters of mercury diastolic. And coming to this dyslipidemia, which is very, very important, C stands for cholesterol. So always remember ABC, A1C, blood pressure, cholesterol, or else you call it HDL, okay, hypertension, dyslipidemia, and something else, okay. So you need to meticulously control these three parameters because these are all the chronic therapy segment and the lifestyle changes. If you can manage to control all these three parameters, maybe you can reduce the long-term complications, let it be microvascular complications or the macrovascular complications. With that introduction, I just get into my topic given today. And once again, I thank USC people. And today we are going to talk about the challenging status quo, the role of statins in diabetic dyslipidemia. It's a wonderful topic actually. So today's index is the prevalence of dyslipidemia, the risk of coronary artery disease, the Indian real world study on the prevalence, the current practice and gap in dyslipidemia management, and insight from Indian experts, the guideline recommendation, the Indian real world study, that is statin in T2DM, type 2 diabetes mellitus. And if you see this slide, it shows you the prevalence of the diabetes in India. So you'll be shocked to see that the prevalence has increased from 7.1% way back in 2009 to 9.6% in 2021. So it's a drastic increase actually. So India ranks a second after China in the global diabetes epidemic with 74 million people with diabetes. And I should tell at this particular juncture that until 2012, the WHO has accredited India as the world capital of diabetes, because we were ahead of China until 2021, until 2012, sorry, until 2012, and later on China surpassed India, and it has become the number one country with this the highest prevalence of diabetes. And now it is, China is taking so many measures, like every measure to stop this the pandemic like thing. Like it's something like the diabetes has become something like a pandemic. I can tell you that it's like a pandemic. It's growing in abnormal proportions. See, I had been to Beijing very recently before this event, the COVID incidents. So I had seen the government of China taking meticulous measures to create awareness, surveillance, screening, mass screening, and how to control, how to prevent at the stage of prediabetes itself, so that they don't get into over diabetes. And sooner, I think, within couple of years, India is going to top the world, and China will be behind us. Again, I fear that the WHO again is going to give us the number one rank, unless until every clinician, every physician, every doctor who is treating diabetes, every diabetologist, every endocrinologist must be so meticulous that we should see to that, we should counsel the patients, we should go for mass screenings and all, create awareness amongst the patient population about the exponential growth of this diabetes, hypertension and dyslipidemia. If we can take the measures very meticulously, so that to cut the rate down of this particular exponential growth in the diabetes or hypertension or say the dyslipidemia. So whenever I say diabetes, it refers, as far as this evening is concerned, as far as my talk is concerned, it is type 2 diabetes mellitus actually. So they're not changes, nothing of that sort. See, I go out of the box and tell you, okay? Don't worry about the slides, okay? It is moving, okay? And slides are not moving. Hello? Yeah, can you see the slides moving? Yeah, I'll definitely do that, okay. Is it visible now? So you're not able to see my screen, huh? Here we are getting the screens. They're like, I'm able to see the screen actually. Is that okay? Oh, there must be some technical glitch. Okay, just give me a second. Okay, I'll try to rectify that. Okay. So not able to see the slides. Sajesh? Yeah, tell me, Shajesh. Okay. ఇక్కడ మూవ్ కావట్లేదు అసలు. ఇక్కడ కావట్లేదు అసలు. Yeah, are the slides moving, Dr. Sajesh? Yeah, I'm extremely sorry for the technical glitch. Yeah. Fine, okay. I was talking about, sorry for the technical glitch, dear my participants. And the last thing in this slide says, nearly 53% of the adults with diabetes are undiagnosed in India, which is approximately like 40 million people. And I would like to be honest in this issue. Even the most the advanced countries like the United States of America, the United Kingdom, even you take the European Union, everything, wherever the advances are taking place, the most the developed countries in the world, the 50% of the people suffering from type 2 diabetes are still undiagnosed. Likewise, the scenario is same with hypertension. Even the most sophisticated countries like the United States of America or the UK, they are the 50% less than that and more than that, plus or minus, they are not getting diagnosed, they are not getting the proper treatment. So, a country like India, where there is no comprehensive insurance healthcare system like what we have NIS in United States of America, the NHS, what we have in the United Kingdom, we don't have such comprehensive healthcare system from the government side. The load is on the patient in the form of the consulting doctor, the investigations, and the purchasing the medicines, and periodical monitoring and all. These are all the factors involved, and that is the reason why most of the patients suffering from this type 2 diabetes or this particular the gestational diabetes and the even the other types of diabetes are not getting diagnosed. So we'll move on to the next slide. And this slide shows the more than twofold higher risk of coronary artery disease and stroke in type 2 diabetes mellitus versus without type 2 diabetes. That's what I have told in my introduction itself. See, one heart attack is recorded in the Western scenario, 2 heart attacks are recorded in Indian scenario, and one stroke is recorded there, 2 strokes are recorded here, and I think it is much more. I think it is 1:4-fold increased risk of the coronary artery disease and the stroke with diabetes. Maybe without diabetes it is double the risk, because the genes are the culprit for this Indian the havoc of the coronary artery disease, or per se you say it as now atherosclerotic cardiovascular disease, or the CVD, that is cardiovascular disease, which includes both the heart attack as well as the strokes. And on the right hand side you can clearly see that the higher risk of coronary artery disease in patients with known diabetes and the comorbidities like hypertension. So you can very clearly see from this diagram that we are at a risk of the heart attacks and the strokes, which are the macrovascular complications of this particular type 2 diabetes mellitus. And more than twofold high risk of CAD and the stroke in a diabetes mellitus patient with higher HbA1c versus without diabetes. Based on this, we have conducted a real young study to understand the prevalence of dyslipidemia in the young Indians. This is very important because the young Indians are at great risk of dying of either the coronary artery disease or the stroke, because the take home message here is we think that only the dyslipidemia starts after this particular once the patient is diagnosed or labeled type 2 diabetes or hypertension, whatever it may be. I mind you once again, the process of the atherosclerosis starts from very early in the age, like to tell you very honestly, from 7 to 8 years it starts to rise and it gains a momentum, and about 12 it gains a peak, and at the age of 20 to 40 it becomes the peak where you find the maximum atherosclerotic process, which leads to this particular what we call our Indian scenario is very typical dyslipidemia, unlike the Western scenario. And we used to see that particular the low HDL with high triglycerides, and now that the scenario is changed, we are seeing the three defects. The LDL is also very high, and the triglycerides are also very high, and the HDL is very low, either in males or in the females. So we need to take care about the young Indians to prevent the further attacks of CAD or stroke. And the risk factors and the comorbidities and the atherogenic dyslipidemia in Indian young patients with dyslipidemia in hospital and clinic, that is the real young dyslipidemia study, and the total number of subjects included were 8,135, and percentage of patient and with dyslipidemia and comorbidities, like you can see the figures, alone dyslipidemia it is 12.9%, that is 1050. Dyslipidemia with hypertension, the diabetes mellitus is 33.6%, that is 2732, and the dyslipidemia with hypertension, that is 14.4%, that is 1175, and the triad is, that is dyslipidemia associated with diabetes mellitus and hypertension, is 39%, that is 3178. And the most common diagnosis across the three age groups was a triad of dyslipidemia, diabetes and hypertension, which was 37%, 33.2% and 41.8% respectively. And dyslipidemia with diabetes mellitus alone without hypertension was 32.9%, 35.2% and 32.9% respectively. And now you see this, the duration of dyslipidemia is highest amongst the age more than 35 years. That is the reason why USC people have chosen this this particular this study, which is purely Indian based. They are doing lot of studies, and they are conducting lot of seminars, webinars to raise the awareness of the clinician population. So I thank USC people for doing that. And you can see the lipid parameters according to the HbA1c levels. So the parameters given are the triglycerides and the total cholesterol and the low density lipoprotein LDLC and the HDLC, and you can very clearly see that the HbA1c, if it is less than 6.5%, and you can see the difference if the HbA1c is around or more than 6.5%. So all these things, if you see the p value, it is all the time less than 0.001. So all the four parameters are statistically very, very, very significant. So the key role, what I said in the introduction, that is keep a watch on the HbA1c very meticulously once in 3 months, in case the patient is affordable to go for that, or at least twice in a year as recommended by the American Diabetes Association. And the HbA1c around or more than 6.5% is the predominant risk factor attributable to dyslipidemia, that is higher levels of triglycerides, total cholesterol, LDLC and the HDLC. And the high prevalence of dyslipidemia with comorbidities in the young Indian cohort, the history of diabetes mellitus, hypertension were the predominant risk factors attributable to dyslipidemia. Now it is HDL. So everything has come: hypertension, diabetes and the lipids, or the ABC I said, A1C, blood pressure, cholesterol. Remember these two things, that's all. So the maximum Indian patients did not achieve LDLC levels as per the ADA 2018 targets and not receiving statins in the recommended dose. I have told you in the very introduction that I am sorry to say that again and again the maximum patients are not receiving who deserve a statin are not getting a statin, that too in a proper dose, that what is recommended by the international authorities, or you take our own the Lipid Association of India guidelines. And the current practices of management of dyslipidemia and type 2 diabetes mellitus in accordance with the American Diabetes Association ADA guidelines, a subset of analysis from the real world cross-sectional observational study, that is LEAD study, which was evaluated 199 sites in a real world setting across India for dyslipidemia management practices in 4,200 type 2 diabetes mellitus patients. And you can very clearly see this in the slide, and you can see the risk stratification and the risk based the LDL lowering therapy assessment in study population using ADA 2018 recommendations. You can clearly just go through the slides, and the participants less than 40 years of age, we find 80% and 64.2% did not achieve target LDLC as per ADA 2018 guidelines. See, it's very pathetic that 80% did not achieve the target LDLC goals, and the patient subset of less than 40 years of age, and 83.3% and 15.6% of the participants were not receiving statin in the recommended dose with atherosclerotic cardiovascular disease and the atherosclerotic cardiovascular risk factors respectively. And coming to the second category, that is around or more than 40 years of age, it's very pathetic that 88% and 91.5% did not have the LDLC levels as per the ADA 2018 guidelines, and 77.9% and 87.2% of the participants were not receiving the statins in the recommended dose with atherosclerotic cardiovascular disease or with the atherosclerotic cardiovascular disease with risk factors respectively. This is a pathetic scenario actually. And the sub-analysis of LEAD study shows suboptimal adherence to ADA 2018 guidelines for the management of diabetic dyslipidemia. And now, if you watch this particular this thing in a multi-site study in India, the India Heart Watch 2, the suboptimal prescription of statins in patients with diabetes, a prescription of high dose statin was low in all the patients suffering from diabetes mellitus, including those at high risk. Now, on the right hand side, you can see the bar diagram which shows that the first color is less than 40 years of age, and the second bar is around 40 to 49 years of age, and the third bar says 50 to 59 years, and the last bar is around 60 plus years of age. And if you take these three bar diagrams, the first one is statin use and the incidence in the men and the women. You can very clearly see that the p-value is again less than 0.001. That is very statistically very significant. And Indian experts agreed to particularly on this early initiation and optimal dose of statin in dyslipidemia management. And in this regard, I would like to say that the early initiation of the dual therapy in type 2 diabetes is very important. The early initiation of insulin is very important in management of type 2 diabetes mellitus. The early usage of the combinations is very much important. Likewise, even in the hypertension, don't rely on one single agent. Along with the lifestyle modification, that is diet and exercise, along with this therapeutic lifestyle changes, that is diet, exercise, the reduction in the weight and cessation of smoking and cessation of alcohol, and like DASH diet, which is in hypertension, that is dietary approaches to stop the hypertension and to control this particular dyslipidemia, which is anything you take, diabetes, you take hypertension, you take the dyslipidemia, the integral part is not the drugs but the diet and exercise and reduction in the weight, cessation of smoking and cessation of alcohol. After that, definitely the role of drugs, they come into play, and certainly we are going to, that's what the key message is. Please don't hesitate to prescribe a statin, don't hesitate to use the combinations, and don't hesitate to hit early and hit hard. Now the funda is simple, either the management of diabetes or the hypertension or the lipids. It is hit early, hit hard to control the diabetes, control the hypertension, control the dyslipidemia, putting them all the figures, the fasting plasma glucose and the postprandial plasma glucose and the A1C, which is called the glycemic triad, as well as the hypertension, use a triple combination as far as this particular dyslipidemia to prevent the further complications of the type 2 diabetes. And the insights from the Indian experts, the methodology was the healthcare professionals, 261 healthcare professionals were invited to participate in the survey that included a standard questionnaire of 18 questions about early usage of statin in the diabetes population of India. The survey results were discussed during the 16 Pan-India RTMs, and opinions from the experts were noted. On the basis of these opinions, the recommendations were derived on the early and pragmatic use of statins in the diabetes population of India to prevent the risk of atherosclerotic cardiovascular disease. This is very, very important. And if you see that the first one, we take the parameter, the outcomes of the early initiation of statins. 78.1% of the healthcare professionals considered that early initiation of statins among the young adults with diabetes results in reduction of the future cardiovascular events, and the 60.4% they opined that that reduces the reduction in the major coronary events, and respectively 53 reduction in the subclinical atherosclerosis, and 50.8% that helps in prevention of heart attacks in the young age, and 42.7% helps in prevention of strokes at young age respectively. and this is to be like it is to be published actually. And if you come to this the initiation of statins, so 56% of the HCPs would initiate statins in patients aged around 41 to 50 years, irrespective of their total cholesterol bar LDLC levels, and 39% of the patients they considered LDLC more than 100 milligrams per deciliter to initiate statin therapy in the patients aged around 20 to 39 years with ASCVD risk. And you take the left hand side, the bar diagram which shows the age group to initiate statins in diabetes mellitus irrespective of total and LDL cholesterol. See, this slide definitely reminds me of the landmark trial, that is HPS, that is the heart protection study, which was published in 2003, that was done in the United Kingdom for 4 years, from 96 to 99 actually. So it's a large study which included 20,536 patients suffering from type 2 diabetes mellitus and dyslipidemia, and they just wanted to see how far it's going to reduce the incidence of the all-cause mortality with this particular the intervention of simvastatin was the drug used in the dose of 40 milligrams per day, and the versus placebo, and one arm was put on the antioxidants and the vitamins, multivitamins, and it clearly showed that the usage of statins irrespective of the baseline lipid parameters. So you don't need to go for any lipid profile as a fasting or non-fasting. They just did that, and they had proved that a significant reduction was there in the all-cause mortality in the group where they have put the patients on the simvastatin 40 milligram. But in our scenario, I tell you, just remember 2 statins. Forget about the pravastatin and the simvastatin and the lovastatin and pitavastatin. You forget about every statin. There are only 2 statins. That's all. In our country, there are only 2 statins. You remember that it is atorvastatin and the potent rosuvastatin. That's all. You remember these 2. Don't get confused. Okay. And left hand side. The age group to initiate statins in diabetes mellitus irrespective of total bar LDL cholesterol, and the majority, like 56.1%, they opined like that to be initiated in between 41 to 50 years of age, and the second thing is 22%, they opined that it should be started in the age group of 31 to 40, and so on. Coming to this, the left hand side, the right hand side, the LDLC levels you can consider for initiating the age group of 20 to 39 years of patient, the people who are they're suffering from type 2 diabetes mellitus, and 38.9% they said yes to this, and 26% said when the LDLC on the this thing the Y bar, you can see the LDLC levels which is in milligrams per deciliter, that is the 38 around 40% opined that the statins must be initiated if the LDLC is more than 100, and the 26% they said that the statin to be started when the LDLC is more than 130, and 13% said more than 150, and the others are not very significant. And it should be like you should start the statin in the very young age, like 20 to 39 years of age group who are suffering from type 2 diabetes mellitus. They should be put on a statin irrespective of the baseline LDLC, or see even American Diabetes Association also had said, clearly mentioned that the usage of statins is very much underused, and it also said that the metformin is very much underused in pre-diabetes. See, it's a pathetic scenario where the drug is to be initiated, we are not initiating. So this is what is happening in our day-to-day practice. Maybe the clinicians are busy, whatever it may be. Once you start treating the patients suffering from type 2 diabetes mellitus, the added complications, associated comorbidities like hypertension, dyslipidemia and all. And dyslipidemia is an integral part of type 2 diabetes. You cannot separate dyslipidemia from type 2 diabetes. You cannot separate dyslipidemia from hypertension. And when this triad is there, it's something like a fire that you cannot extinguish. Please, so I request all the participants, the key home message is, try to initiate the statin therapy, the right statin like rosuvastatin, very early in the disease process, so that there won't be the atheromatous plaques and all, the coronary blocks and all. You can prevent them. You try to reduce the LDLC, and now the guidelines have changed that. So instead of 100, now it is like it should be less than 70 in like patients with mild risk factors, and with the intermediate, the moderate risk factors, it should be less than 55 milligrams of deciliter, and with high risk, it is 40, less than 40 milligrams of milligrams of per deciliter. This particular very high risk, the high risk group, and less than 30 in the very high risk group. The least being the less than 30 is the latest consensus for the level of LDLC in very high risk groups. So remember the figures 70, 55, 40 and 30. Okay. And this slide shows the percentage of patients, the left hand side, you can see the less than 40 years of age, and on this 32% of the healthcare professionals would initiate statin in 16 to 30% of their patients aged less than 40 years. So you can clearly see this age and the 32% they opined, and they coming to the right hand side, the percentage of patients in age group 40 to 75% was with the risk of atherosclerotic cardiovascular disease, and 70% of the HCPs agreed to initiate statin in more than 40% of their patients with diabetes aged around 40 to 75 years and not having atherosclerotic cardiovascular disease. And the initiation of statin therapy, now you can see the bar diagrams. The green is the green is they strongly agree, and the next one is agree, and the light yellow is neutral, and the brick red is disagree or strongly disagree. The early initiation of statin in diabetes with additional atherosclerotic cardiovascular risk factors will help to reduce the cardiovascular disease in those patients. It's a question mark. Okay. Every diabetic in India is from 40 to 75 years with no atherosclerotic cardiovascular disease should be on at least moderate dose of statin for CAD prevention. So 98.9%, that is almost 99% of the HCPs agreed that the early initiation of statin in the patients with diabetes and the atherosclerotic cardiovascular risk factors will help to reduce the cardiovascular disease risk, and 90% of the HCPs agreed that every diabetic in India 40 to 75 years of age group with no ASCVD should be on at least moderate dose of statin to prevent the cardiovascular disease. And now coming to the this particular slide says the 51.2% of the HCPs recommended to initiate moderate intensity statins, and 43.8% of HCPs recommended low intensity statins, and a total of 78.5% of the HCPs recommended the usage of rosuvastatin for early initiation in patients with diabetes aged around 20 to 39 years, and assess for tolerability and compliance for every 3 months. See, once you start statins, you must be like very vigilant and just put a word to the patient after starting this particular statin. See, if you notice body aches, myalgia like things, please come back and report, because if we can, this is very rarely seen. The rhabdomyolysis, which is supposed to be the one of the complications of the statins, is a very rare entity, because so far in my 30 years of my clinical practice, I've seen hardly 1 or 2 cases. That's all. And if you change the statin, they just accommodate to that particular statin. You start with a low dose, keep increasing, keep increasing, keep increasing. So and the other the complications, what is said, the statin induces the new onset type 2 diabetes mellitus, which is not seen in my clinical practice, but it's a very important the particular incidence of the statin induced diabetes. So you keep assessing the liver enzymes at least once in 3 months, so that there will be little bit of elevation in the liver enzymes when you put the patient on statins. Take the baseline LFT, compare, and if everything is fine, and if it is twofold, you don't need to worry. If it is threefold, you don't need to worry. If it is more than threefold when compared to the baseline, it is high time you need to intervene. And so this is the 93.5% of the HCPs agreed that rosuvastatin has more clinical utility compared to other statins due to better LDL-C lowering effect and other pleiotropic effects. The best part of the rosuvastatin is that it doesn't stop with lowering the LDL-C. It decreases the triglycerides very significantly, and it increases the HDL-C also significantly, where when compared with atorvastatin, see the rosuvastatin scores in that particular aspect that apart from reductions in the LDL-C, it also reduces the triglycerides and it raises the HDL-C also. That is the reason why people are moving towards the evidence-based medicine, which shows that rosuvastatin has got a lot of advantages when compared to atorvastatin. And I mind you once again, in acute cases where the patient has got the myocardial infarction, or where the PCI, the percutaneous coronary intervention with stenting is required, where the patient requires cabbage, that is coronary artery bypass graft, still the gold standard drug is atorvastatin. To start with, it is 80 milligram, and later on, depending upon that, the cardiologist may come down to 40 milligram. And but for that, in all the cases, to prevent the attacks, to prevent the strokes, to prevent the atherosclerotic cardiovascular disease, the rosuvastatin is the best drug of choice. And so for early use of diabetic population, rosuvastatin has more clinical utility compared to the statins due to the better LDL-C lowering effect and other pleiotropic effects. It is around some 36.2% said they strongly agree, and 58% said they agree. And there is no need to increase awareness of early use of statins for primary prevention of cardiovascular disease among Indian healthcare professionals. 53 point they said they strongly agree, and 43.8% they said they agree. So a total of 55.8% of the HCPs considered that the physicians in